Hello, you're watching sqadia.com, and today our lecture topic is acute haematogenous osteomyelitis. In this, we will be discussing the etiology and pathogenesis, its clinical features, its differential diagnosis, what else we should be thinking when we are dealing with acute haematogenous osteomyelitis, and its treatment. Mainly, it's a disease of children. Different studies from UK confirm a low incidence, less than one case per 100,000 in most recent periods, although it's almost certainly much higher among less affluent populations. Now, this kind of infection due to a higher rate of sanitation and proper medications and all this, actually the infection rate has gone a lot down, but still it's quite a bit of a problem in third world countries. Etiology: what are the organisms which affect and cause acute haematogenous osteomyelitis? The most common and the most notorious is Staph aureus or Staphylococcus aureus. Then other includes group A beta hemolytic streptococci, which is also called as Streptococcus pyogenes. Staph aureus, Streptococcus pyogenes are all gram-positive organisms. Streptococcus pneumoniae is also gram-positive. H influenza, although its incidence is decreased. Why? Because now at 9 months, an infant actually receives a vaccine which includes Haemophilus influenza vaccine. So due to this introduction of vaccination, the rate of Haemophilus influenza infection has gone really down. But there is still incidences, for example, in which countries where there is no clear-cut there's no clear-cut guidelines for vaccination, or for some other reasons the vaccinations do not occur. As a result, in those countries still Haemophilus influenza is quite common. Other include the Hackett group, which Hackett group actually includes a multitude of organisms, which includes Echinella, Hackenella, Cleganella, Echinella, and Kingella. Now, Kingella is one of the type which starts from K. This is part of the Hackett group, which may cause acute haematogenous osteomyelitis, but most common and most notorious among all of them is actually Staph aureus. Gram negatives include, then these are the gram positive. Other include, it could be E. coli, it could be Pseudomonas, it could be Proteus mirabilis, anaerobic bacteroides, fragilis, or it could be sickle cell disease or prone to infection of Salmonella typhi. For example, especially if a child has a sickle cell disease and suddenly gets acute homogeneous osteomyelitis, you must be suspecting Salmonella typhi. Because E. coli, Pseudomonas, depending upon if there is a catheter in place, the child was already sick, and there was a lot of tubes in place in the body, they all can have these kind of Pseudomonas, Proteus, and E. coli. But usually gram negatives do not occur as a first instance unless first hit has been done from the Staph aureus and overall the immunity is live, and then there is multi-infection, or there are infections from other organisms above Staph aureus. Coming to the etiology and pathogenesis in adults. Source of infection may be a urethral catheter, indwelling arterial line, or a contaminated needle or syringe. And how this infection spreads in children? Now, this is an important diagram, because as I just told you that it's a closed compartment. If a infection starts in the metaphysis, it will stay in the metaphysis. It will not cross the epiphysis and goes into the epiphyseal area. But in children, it's slightly different. There is always a chance that it starts in the metaphysis and then crosses the physis, goes in the epiphysis, and eventually goes into the joint. The reason is, in children, usually osteomyelitis can result in arthritis, and arthritis can result in osteomyelitis. Why? Because of the anastomosis which is usually present. If you see it over here, these are the metaphyseal arteries and these epiphyseal. They have connection across the epiphysis between them, and this, once the infection starts over here, this can spread to this area, or if it starts over here, this can spread to this area. Coming to the etiology and pathogenesis, acute haematogenous osteomyelitis shows a characteristic progression marked by inflammation, suppuration, bone necrosis, reactive new bone formation, and resolution or healing. Now, this is a diagram which is showing this is the formation has taken, the infection has taken place over here in the metaphyseal region. Now, once the infection starts, there will be a host response. There will be neutrophilic infiltration. There will be lymphocytic infiltration. Eventually, neutrophils become multinuclear giant cells and polymorph nucleocytes. Once they start, they will try to wall off the infection. But if they are unable to wall it off, this would result in exudative pus or suppuration. And this suppuration will start spreading from metaphyseal area down to the diaphysis, and it will cross the epiphysis to go epiphyseal plate and cross that to go into the epiphysis. As you can see it over here, that sometimes this can cross and goes into the joint, and sometimes instead it crosses all the way to the skin where it forms these sinuses. As the bone grows, and as you can appreciate over here, that actually the periosteum is lifted off, but the infection is actually not spread beyond periosteum. So as a result, the cells over here would be simply deprived of oxygen and nutrition. As a result, they will start going into necrosis. So first it's the inflammation, then it's the suppuration. The third stage would become the bone necrosis. Once the necrosis starts to develop, then this necrotic patch would be actually removed, and body will try to make a new bone. And this new bone formation would take place in those necrotic patches which would be here. Now, this necrotic bone is actually termed as sequestrum, and the reactive bone, which is new bone formation, is called involucrum. And sometimes when we are in the era of antibiotics, and as a result sometimes this can be contained. As a result, a resolution and complete healing occurs. But if resolution and complete healing does not occur, this acute infection will progress to chronic infection. Coming to the infections in children, neonates and adults. Classical picture in usually it is between 2 and 6 years. Swelling, pain and loss of motion at a joint. So I already told you the classical features of infection is basically pain, swelling, redness, loss of motion at a joint. Coming to the clinical features in children, it's severe pain. If it's acute, this is usually sudden and severe in onset. There is a lot of malaise and fever. In neglected cases, toxemia may be marked. The patient may be so toxic that actually it's not really clear that whether it was a single joint involvement or the whole body is actually has involved. But sometimes it's such a rapid spread that patient is toxic, and the clinician is more focused to sort out the toxemia of the patient rather than focusing on the acute hematogenic osteomyelitis of the bone. Child refuses to use one limb. If it is going to be painful, definitely they're going to be they put their limbs usually in some kind of a posture. If it's hip, they usually adduct it, or if it's knee, they usually flex it. But as you try to extend the knee or abduct the hip, what actually results in stretching and pain. So they refuse it. Either they cry on moving their limbs, or they refuse to move their limb, so that because it's kind of a painful. There would be a recent history of infection. For example, sore throat or boil. Definitely, it's most common the acute hemogeneous osteomyelitis spread via bloodstream. So usually there is sometimes a distant history of infection. Somewhere else, actually, the infection seeded. It traveled by the blood and resulted in infected that bone and part of the joint. Acute tenderness near one of the larger joints and associated lymphadenopathy. And then there are constitutional symptoms. In neonates, it's sometimes very difficult to diagnose acute osteomyelitis because they just cry. They cannot tell you that what's wrong with them. Baby simply fails to thrive and drowsy and irritable. It cries a lot. Usually swelling, hyperemia is present in any one large joint. And sometimes the problem lies in this joint, because when you try to move it, the child really cries a lot after moving of that limb or that part of the joint. Coming to the diagnostic imaging. In orthopedics, whenever we are having a problem, definitely the first and foremost thing to go is always the X-rays. If a child comes to you and complains of having a fever for 2 to 3 days, there is definitely he's looking toxic, or he's looking at least feverish. Then parents complain that he's not moving his or her right hip or right knee, for example, and then you just assess it and you see, okay, there is a swelling present over there. After taking a detailed history, you probably would be going for the x-rays, and if the knee is involved, the first and foremost would be the x-rays, knee, AP and lateral view of the affected joint, and contralateral may be needed as well, to so that that can be compared with other limb. If there's if it's something, if the clinician is suspecting other than the infection, then should also get a comparable view. Otherwise, usually if in case of infection, it's that extremity which is involved, and AP and lateral view of the joint which is usually involved. This is the diagram which is showing AP view of the right knee. As you can see it over here, now this is looks almost normal, but as you see over here, there is more of lytic lesions over here. There is a lytic lesion, there is a lytic lesion over here as well, and increased haziness. There is some degree of swelling as well, and showing some kind of exudate accumulation. Now, as this is progressed, acute hematogenous, as you can see, the lytic lesions is actually increasing. It's now over here as well. So that means this suppuration stage is actually initially was present up to here. Now it has reached over this level. Once the suppuration stage set in, there will be actually bone necrosis, and then there will be new bone formation, and that would call be involucrum. Other diagnostic imaging, ultrasonography is useful, but at times it's cumbersome, because dynamic ultrasonography, for that you need to move the joint, and moving the joint is so painful that usually it's avoided. But it can also be utilized, for example, if you need to aspirate some kind of a pus, and this pus is not so evident, although there's some pockets of pus present. By ultrasound you can localize where those pockets are, and those can be aspirated for culture and sensitivity and biopsy of those lesions. Then is the CT scan. CT scan can be utilized if we are on plain X-ray, it's all normal, and on ultrasound you cannot find a lot of pus, then probably CT scan would be the best option to show the bone quality. Other imagings we use usually for infection are radionuclide scanning. Now there are three of them, include technetium 99, it's gallium 67, and indium label 111. Actually, indium label leukocytes are most specific for infection, because wherever there would be infection, definitely there will be lymphocytic infiltration, and if those lymphocytes are labeled with indium radioisotope, then they can be easily traced to see whether there has been infiltration of lymphocytes or not. Coming to the lab investigations, if you're suspecting a child or just a young child or an adolescent with acute osteomyelitis, then most certain way to confirm a clinical diagnosis is to aspirate the pus or fluid from the joint. If it's metaphyseal subperiosteal abscess, the extraosseous soft tissue or an adjacent joint. Now, ideally, in any infection, one must isolate the microorganisms. So, if microorganisms are isolated, then you can confirm that yes, there was an infection. But all other things like blood cultures, other than these, are actually indirect way of determining whether the infection was there or not. Definitely you need blood CP. Now blood CP is important because it will show you whether there's signs of infection or not, whether there's raised TLC count or not, and if it is raised TLC, what are the differentials in it? It is neutrophils which are raised, which means acute, or it is the lymphocytosis which has occurred, that means some kind of a chronic infection, or and then if there is a degree of anemia present or not. Usually in acute there is no anemia, but in chronic there is sometimes CP shows a picture that in which there is anemia of chronic disease. CRP stands for C-reactive proteins. Now they would always be raised in acute infections, although they are highly sensitive but not specific, because they can be raised in a multitude of other conditions. and usually they're not specific for infection or acute hemogeneous osteomyelitis. ESR can be also simply, it is a prognostic marker. If it's coming down, which means the infection is settling, but it's not specific marker. It cannot tell you what type of infection it is. The only thing which will tell you is the culture report of that pus or aspirate which has been taken from the joint involved. Others which have nowadays, new research has shown that these, once the lymphocytic and neutrophilic infiltration takes it, they release a lot of mediators like interleukin 6 and alpha defensin. Now they can be taken out of this joint, and their levels can be measured, which would directly correlate with the amount of infection. But what organism is involved, that would only be we would be able to confirm it on the cultures we have taken from the joint. Coming to differential diagnosis, for example, if a child comes to you with a swollen knee, with orangish reddish knee, and there is 2-3 days history of let's see, pain, swelling, fever, and now he or she is unable to move or bear weight on his right knee, what would be your differential diagnosis? It would be definitely, you'll be thinking of acute hemogeneous osteomyelitis, but what others? Those would include cellulitis, because it could be simply soft tissue infection and involving above the subfacial planes. It could be arthritis or acute suppurative arthritis. It could be streptococcal necrotizing myositis. It could be acute rheumatism. It could be sickle cell crisis, or it's this. Usually with fever, if fever is not present, it's only swelling, and there could be certain metabolic diseases. For example, Gaucher's disease, in which there is due to accumulation of certain metabolites, there is swelling of the joints, which may cause a picture which is similar to acute hemogeneous osteomyelitis. Coming to the treatment. Now, coming to the management of the patient, will start from the history, a detailed history of and what possible was the cause of infection. Was there any host in compromise or not? What are the bacterial factors which could have resulted in this infection? And then from after history and taking a thorough examination of the joint involved and other joint which could be involved, especially analyzing whether there was lymphadenopathy present or not at the time, then it actually comes to the treatment of the patient. It starts with the appropriate antimicrobial therapy, because we know we are dealing with microorganisms here, and we have to have a antimicrobial therapy, which is initially empirical, but as you take the cultures during the initial investigation, you wait for 72 hours, because that is why these cultures are foremost important as well. You need to have a definite organisms, and then you need to have sensitivity against those organisms. You need to know that, okay, these are the medicine which I can give, and I can kill this organism so that it does not get complicated. Then if it has become complicated for any reason, for example, there is pussy discharge, or there is a lot of accumulation of pus, then pus has to be drained. That is, if it is there, it has to be drained. And then, for example, a child comes to you with a swelling of hip or knee. Now he or she cannot bear weight, and if he or she's gonna move the limb, whether it's hip or knee, that is gonna be very painful. So you need a splintage of the rest, and the rest of the factor part is very important. What actually results is that rest and splintage not only removes the pain, but also allows this healing process to go on smoothly. Coming to the supportive treatment, usually whenever there will be pain, yes, definitely analgesia has to be given. Dehydration, in most of the cases, there are usually children, and children do not actually, when they are sick, they do not eat. So there is always some degree of dehydration which is always there. So if that has to be assessed, if there is, and there is acute dehydration, that can be even intravenous fluids can be given, or simply oral rehydration salts can be used to cover for that rehydration, but that has to be supplemented, because it's a holistic approach has to be taken. It's not only joint specific, we have to look at the whole patient actually. Keep watching sqadia.com. Thank you very much.